Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
All right, so I'm just going to kind of dive in and explain a little bit first about my training. So residency, it's 3 years, but first you have to do 1 year intern year. I did mine in a surgical transition year, meaning it was pretty much a split up between medicine, surgery. I did some pediatrics, I did some intensive care unit work, and then just a lot of electives too. So that was good. I got a lot of experience. I actually did brain surgery once, so that was kind of exciting to, get that under my belt. And then so I did residency for 3 years, and pretty much what that entailed was I worked in a private office setting, and also a hospital setting. Very different. The hospital setting is really where we store most of our pathology, and that's mainly where we operated as well too. It was actually, and no one really believes it until they see it firsthand. Residency was quite difficult, and I say that because you're taking home call. So you'd work a busy day in the clinic or in the operating room, and then you would cover 4 hospitals. So if you were primary call, and that's what the first and second years were, you're covering 4 hospitals. Plus, they would get a lot of transfers, and I was out in Long Island, so all the private ophthalmology, or excuse me, all the private hospitals would transfer their ophthalmology patients to us. So even if you got a couple consults, you could be up all night and then working the next day. So that was actually pretty challenging. But you did you got a lot of good experience doing that. And I'd always say for anyone doing any type of training, as painful as it is in the beginning, you want to get that training, because then, when you're out of training, you know that this is something that you can handle, without a problem. So we did that. Again, 30 years mainly when you're operating. And that's when you're doing your cataracts. That's our bread and butter surgery. So we did a lot of cataracts at the city hospital. And then we'd also operate it with retina people as well too in the private office. That was mainly assisting them. As we mentioned, retina is one of the more technical types of surgeries, and a lot of ophthalmologists do fellowships. I think it's about like 80-90% now. I'm a little bit of an anomaly, just doing general or comprehensive ophthalmology. But we'll talk about the fellowships in a second. What I do now, I work, as I mentioned, in a private office, but I also work in a city hospital. And that's nice. I work on the Lower East Side, and that hospital, we see a lot of pathology there, definitely a lot of language barriers, but it really is nice. Even with the language barrier, there are a lot of people there to translate for me, and the patients are very appreciative. It's a slower pace. Again, it's nice. You're not really worried about any overhead there. You're just kind of making sure that the patients are being treated well. And again, a lot of pathology there. You're going to see just a lot of different things. And then I also work in a private office. I work actually with my friend and his father up at Columbia University. I'm not staffed at Columbia, but my friend's dad works at Columbia University, and then he has a couple different private offices, which I work at. We see a lot of patients there. It's my friend and his father are very busy surgeons, and pathology really depends on where we are. But again, it's a lot of work, but at the same time, we have a lot of help there. That's a big thing, just having a lot of different staff to help screen the patients. They're checking vision for me. If a patient comes in wanting, a glasses check, they're taking care of that before they see me. And we have a lot of nice technology. So we get a nice big photo of the back of the eye before I even see the patient. Any testing that I need is already done. The staff is really good at anticipating my needs and what I might order for the patient. So that's really good. And again, for any real specialty, I'd say it's great to just have good staff, because they could, it comes to a point where they know what you're going to do, because, 80% of the time it's going to be, a similar thing. So it's good that they're able to do that. Again, kind of touches upon too about how I gave up operating, but you can still kind of find your niche, because my friend and his father just love doing cataracts. So it's a nice kind of symbiosis where I'm not trying to take their cataracts, and I'm just trying to, help them out and make sure that the patients get good pre-op and post-op care. What we do pretty much, it's a lot of routine just exams, people coming in to get their eyes checked. In pathology, we see cataracts, glaucoma, diabetic retinopathy, dry eyes, macular degeneration, chalazion. In what I'm doing a lot of office procedures, a lot of lasers, a lot of INDs, punctal plugs, and injections. And we'll get into that in 1 second. I just kind of want to go over kind of our basic pathology. Basically, what a cataract is. Very common. You're looking at them pretty much in anyone over than 50 will have some signs, but even babies can get them. So there's no real age limit. People, it's funny, you got to be careful how you speak to patients, because sometimes, they could be maybe 55, 60, very small cataracts, and then mention that they have cataracts, and they lose it. They get very upset, and I try to explain to them that it's perfectly normal and it's not anything bad. But basically, what a cataract is the lens in our eye is a little M&M, so to speak, or the size of an M&M, and it's clear normally when we're born, and then over time, it just kind of the proteins change, becomes cloudy. So becomes cloudy. And then eventually, kind of like a cloudy window, it has to be replaced. And that's what cataract surgery is, taking out the old lens, putting in a new lens. This is one of those things where you really do have to listen to what the patient is complaining about, because you might have, a fighter pilot in your chair, and they're all of a sudden 2025 and they're not perfect 2020 and they hate it. But you could have someone who's 2040, 2050, and they can still watch TV and they're happy. And there's someone you're going to want to leave alone. Very important, you got to, what we do is for cataracts, we got to do accurate measurements. So we're measuring the curvature of the front of the eye, we're measuring the length of the eye. And based on that, we're figuring out, when I say IOL, that's the lens that we're going to put in the eye. Talk about different options for them. So that's a big thing too. Glaucoma. I feel like everyone's, grandparent has glaucoma, or, people have heard of glaucoma. This is a disease of the optic nerve. This is a very dangerous disease, especially in a lot of minority populations, like the African-American population and Hispanic population. For whatever reason, and we don't know exactly why, but it affects those populations more, and it can also be more aggressive. And what's really bad about this is it's asymptomatic for the most part. What happens is it's usually associated with high eye pressure, but not always. And what happens is we start to lose our peripheral vision out here, and then it kind of constricts, and then to the point where it's tunnel vision, and then the nerve just stops working and we can't restore vision. Basically, the treatment for this boils down to lowering the eye pressure. Variety of ways to do that: drops, medicine, lasers, surgery. But you always, if the nerve looks even just a little bit different, or the pressure is a little bit high in the eye, I'm always counseling the patient that we need to do testing. Testing involves doing peripheral vision tests, a visual field. I don't know if anyone's ever had that, but it's basically putting someone in a machine, and they press a button every time they see a light. Pretty much just doing like a boring video game. There's some new testing too that kind of, it's almost like an EKG of the nerve. That really hasn't been adopted yet, but that's potentially a more sensitive test to pick up nerve damage before it's visible to us. But really important, and again, because patients will really need to trust you for this, because they'll have no problems. And then you're saying that they need surgery that they're not going to like, and the surgery might not make them see better, might make them see worse, but they need it because otherwise they lose vision. So that's really important to just speak to the patient about, and always screen for. Diabetic retinopathy, that's another big thing that I'm seeing in my office all the time. Anyone who's diagnosed with diabetes has to come in, get screened for any retinopathy. Now, what we're doing here is, again, we always dilate the eye for a patient. But for a patient like diabetic, we're getting fundus photos. We're looking for any types of bleeding, swelling, any types of neovascularization. And what that means is that diabetics just don't have great circulation, and you get areas of ischemia, and what the body does is just kind of grows in new vessels. Those bleed easy. Usually it's in the back of the eye, but it can also be in the front of the eye, and you can just get really bad complications. Basically, there's several indications for treatment, which a little bit too advanced for this. But basically, what we're doing, if the swelling is bad enough, it's really just trying to stop the swelling. And as you mentioned before, it's a lot of injections, a lot of lasers. The lasers are really just trying to burn the little small areas of bleeding to stop the swelling. And the injections are actually, it's an anti-VEGF. And what anti-VEGF is, it still is a cancer medicine, and it stops stops the new blood vessels from being formed. And that was useful for tumors, because tumors would form these just, irregular blood vessels. Someone probably smarter than me thought that we should just put this in the eye and see what happens, and it actually works well. Again, it's not perfect treatment. Again, I always counsel my patients the best thing to do is not to get this, because it's very hard to reverse, but at least stops some of the swelling, and you can see it kind of on, we'll do what we call an OCT to measure the thickness of the swelling, and you could see it go down usually. But really important to screen them. And, this is one thing too, where a lot of patients, tell them their blood sugar is high, and that's meaningless to them. As an ophthalmologist, you tell them you have bleeding in your eye. It freaks them out. And that's, honestly, it's a good thing, because then sometimes that's the kind of push that they need to start controlling their blood sugar. Macular degeneration. Again, this affects Caucasians for whatever reason more frequently. Again, if you see a patient who's 80 Caucasian, they're most likely going to have macular degeneration. Similar to, I don't want to oversimplify it, but kind of the same idea as diabetic retinopathy. I'm seeing this a lot too. You get macular degeneration. I think the best way to describe it to someone who's not an ophthalmologist, it's almost like cracks in the sidewalk. We're born, the retina is kind of like this nice smooth sidewalk. And then as we get older, little small cracks start to form. And that's kind of like the dry form of the macular degeneration. Mm-hmm. That's not necessarily bad. I mean, it's not good, but it doesn't necessarily affect vision, especially if it's a mild form. We just monitor it. We give them what we call AREDS 2. That's a multivitamin that's been shown to prevent the progression of macular degeneration. Tell them to wear sunglasses, real simple stuff, but just, it is important to do the preventative care. The wet is when blood vessels grow in and start bleeding. That's kind of similar. I use my analogy of the sidewalk again. It's kind of like weeds growing into the little cracks. That's bad. That's, again, kind of diabetic retinopathy. You're getting that swelling. You're going to put in anti-VEGF. You're going to try to stop the bleeding any which way you can. That's usually a bad prognosis, and that's unfortunate. Hopefully we're going to get better treatment for it, but everything else really hasn't been shown to work that well. It's really just trying to stop the bleeding with injections and potentially a laser. Dry eyes, we see this all the time too. This is, again, I want to say one of the more tedious things of our field, because you'll get a lot of patients coming in with dry eyes. Some, it's obvious, you give them artificial tears, lubrication, and they're all better. Some, it's just nothing works for them. So other things you can do besides lubrication drops, there's prescription drops like Restasis. That's an anti-inflammatory medicine, cyclosporin, that actually has been shown to just produce better tears. That helps. You can also do fish oil, and you can also do procedures. I mentioned, punctal plugs earlier. What punctal plugs are, it's kind of a cool thing that we do on one of our procedures. We have puncta right here, right here. And what we do is just with like a little forceps, we actually just kind of clog it up with this little microscopic, kind of almost like a drain blocker, for lack of a better word. We put it in their eyes, and again, it's kind of like clogging the bathtub, so to speak, of the eye. Very easy to do. The patient just has to not move, which can sometimes be difficult. But we put it in there, and a lot of patients get good relief. And I remember actually one of my colleagues, I always put it into patients, and I wonder if they're just being nice to me when they say that they're feeling better. But one of my colleagues and friends had dry eyes, so we put it in, and he's like, "Oh, man, that's a lifesaver." So it actually does really help. Sometimes you even put them on mild steroid drops. But again, this is just a really common complaint that as an ophthalmologist you're going to see all the time. So lots of artificial tears for our patients. Chalazion, styes, the common name for it. We see this a lot too. Again, it's really kind of my silly analogy. It's kind of like a fancy pimple of the eyelid. It's not an infection, but basically we have a lot of pores around our eyes. And again, back to the dry eye point. Tears are surprisingly very complicated, and they need the right amount of oil and everything to kind of properly lubricate the eye. I mean, if it doesn't do that, that's a problem. So that's why, again, we have a lot of oil producing glands around our eyes. They get clogged up. I'll see patients coming in who are 7 years old with the sty for the first time, and they think that, something's terrible, and, it's just a clogged duct. So what we do, usually what we do, warm compresses. The reason why that works is that the warmth opens up the pores, helps everything drain. Steroid ointment, and you can also just put digital pressure on it, try to get it to drain. But this is another thing that, in terms of ophthalmology and procedures, this is the big thing where we do, in terms of procedures. You inject them with steroids. That's an easy thing to do. Basically, you just give them a little Kenalog, and inject it into the little bump in their eyelid. That works. Or you could do you could drain it. That's a little bit more involved, but still pretty easy. And you're just putting lidocaine all around their lid, flipping it over. You're putting a little clamp on it, and you make a little small incision, and it's actually kind of gratifying, because once you got to be very delicate and just slowly progress. But then once you do, you get a nice little rush of fluid, and it just resolves on its own. So that's a nice thing. Sometimes it becomes pretty hard, and you're actually kind of removing almost like a little ball in the eye. But the patients are really grateful for when you're able to do that. And then lasers. So this is another kind of big thing that we do in our office. Small point, and it's funny because I'll tell patients that, either they need a laser or they'll come in and they want to talk about laser. And for patients, laser equals LASIK. Most ophthalmologists do not do LASIK. That's a very small part of our field, but for the public perception is a huge part of our field. But just to talk about a couple basic lasers. One of the most common lasers that I do is called an LPI, laser peripheral iridotomy. Basically what that is, I'm not sure if you guys have heard of this, but some people might have an acute attack of glaucoma. And the way I describe that is drainage system should look like that, or the angle should look like that, and fluid's leaving right where my fingers meet, right here. That's a normal angle. For someone who's hyperopic, or someone who has a plus size eye, it means that their eye is a little bit more compact. So their drainage system's more like this. And that can usually work well for a while. But what happens is it can kind of just all of a sudden shut off, and the pressure skyrockets in the eye. Or other times, it doesn't really necessarily shut off, but it just doesn't work as well as it should. And that's more of like a chronic angle closure. Either way, you're going to want to do an LPI on the patient. What that is basically we're kind of lining up two little dots, and we are just lasering a little hole in the colored part of their eye, the iris. And we try to hide it so no one can see it. And it's a very simple procedure. The only problem is sometimes patients have pain because you hit a little nerve, but usually they don't feel anything, or just maybe a little jolt. When they do, it's annoying, because then they'll just kind of jump out of the machine, and then they're all uncomfortable. But for the most part, it's a very easy thing to do. It takes about 15 seconds. Another very common laser that we do is a YAG capsulotomy. Secondary cataract. So basically what happens is for cataract surgery, we're putting in the new lens, and we try to put it into the natural bag, or where the encapsulation of the old lens was. what happens is about 20% of the time, cells will kind of start to proliferate in the back and create, well, again, a secondary cataract. So it kind of clogs up the visual axis again. So what we do, and this is a really cool thing. Again, you're asking about gratifying things. Patients will come back in. They're very concerned that the surgery has stopped working. They think that we need to do something drastic. All we're doing now is dissecting kind of the back part of the capsule. And we just kind of do like little kind of circular little dots to kind of have the capsule just fall back. And by falling into the back of the eye, it opens up, it clears up a nice little circle for them, and they can see well. And they're, again, eternally grateful for you for being able to do that. To speak a little bit about the OR, that really kind of depends on your specialty. For a retina person, they're doing, and again, not that these terms will necessarily mean a lot to people listening to this, but vitrectomy, that's basically like you're sucking out the jelly of the back of the eye. They're doing peels of membranes in the back of the eye. They're putting in gas, and that's all to kind of remove scar tissue and to put the retina kind of back into place for a variety of reasons, whether it's detached, something's pulling on it. But basically, that's what retina is doing. It's a very technical, complicated surgery that requires 2 more years after residency to learn how to do. But they're great. They're wonderful to watch, and if people want to learn more about it, honestly recommend going on YouTube and try to watch them. You're probably not going to understand what's going on because, again, it is very technical, but I think it's worthwhile. Cornea specialists, they specialize in the front of the eye. Their main thing is corneal transplants. They'll either do a full thickness or partial thickness. I don't know if you've heard of people donating their eyes, but this is kind of what cornea does. They're doing the transplant. So you're donating the front part of your eye. And then for whatever reason, if there's scar tissue, if there's inflammation of the front of the eye that needs to be replaced, well, I mean, it's an amazing surgery. They'll remove the top part of the eye. They got to quickly put the new part in because the eye obviously does not like being open for that long. It has a bad kind of pressure gradient. So you're kind of asking for bad things to happen when the eye's not, when the eye's open like that. So they got to put the graft back in, suture quickly. They'll do other types of things like biopsies. So if the pressure is too much in the eye, they'll kind of create another pouch for the fluid to go through. Again, that's a oversimplification, but that's kind of what they're doing. And then there's other new surgeries, minimally invasive surgeries that are usually done with cataract surgery they don't work as well, but the complication rate is much lower. And that's a big thing with glaucoma. They're getting a lot of, because someone could come with a pressure of 40, you do one of these surgeries, and then the next day they're coming in with a pressure of 0. And then it's like, well, now great, now we gotta get the pressure up. And patients are not happy when that happens because, again, glaucoma they were seeing fine, and now you're messing with their eye, and it's tough. Pediatrics, we haven't really spoken about that. This is another great field because strabismus surgery, that's basically eye misalignment surgery. What we're doing there is really just reattaching the muscles on the eye. The eye has a lot of different muscles being attached to it. Kind of just, imagine just almost like a puppet being kind of moved back and forth. And if the eye's kind of going out one way, we'll just kind of adjust where the muscles are. And that can straighten out someone's eye. And you want to talk about, really impacting someone's life. You see someone who has strabismus and you get their eyes straight, they're forever grateful for you. So that's another wonderful surgery that you can do. Ocular plastics, they're doing anything around the eye. Blephs are a big thing that they do. Everyone wants to have their eyelids worked on. But they're doing a lot of non-cosmetic stuff, mainly non-cosmetic. Orbital floor fracture repairs, they're doing the tear system repairs, eyelid reconstruction, and if there's any type of orbital tumor, they're doing it along with either ENT or possibly even neurosurgery. That's another kind of difficult subspecialty, another 2 years of training. Also, very few of them. So it's always good to kind of get a good relationship with an ocular plastic person because they can be very difficult, cases and surgeries. Cataract surgery, it's our bread and butter. We already mentioned kind of replacing cloudy lens with a clear plastic lens. What we're doing is, again, we're breaking up the old lens with an ultrasound probe, sucking it out, sliding a new lens in. That the laser does the incisions, but we're still doing most of the work. Again, it's more, honestly, it's just, I don't want to say a gimmick. I mean, it does help sometimes, but it's really not kind of a major breakthrough in our field. The major breakthrough was with phacoemulsification, which I just mentioned, the ultrasound probe to break it up. Because usually, or excuse me, previously, what we would do is create just a large wound in the front of the eye. Large wound for ophthalmology, but a big wound for us. And we would just push the lens out. I don't know if you've heard of people, maybe your grandparents or, have told you stories of getting cataracts removed. They're in the hospital with sandbags over their eyes. The phacoemulsification really improved the technology where the patient's in and out. It also does create high expectations for us as ophthalmologists because the patients are not happy immediately. They think that something went terribly wrong, which isn't the case. Different lens options. You can do a multifocal lens, so you can do reading end distance, or kind of just a basic lens like a monofocal. To be perfectly honest with you, I always recommend the monofocal. It's cheaper, but it works better. The multifocal lens patients don't like for the most part because you're getting two kind of points of light in the eye, one for distance, one for reading, but it breaks up the light and they don't like that. And I just, it's one part of the field that I don't like because there's a lot of push for multifocal because it just pays more. All my family and friends, and assuming the technology doesn't change when I need cataract surgery, which is hopefully a long time from now, I do the monofocal.
Yeah.
If time, we'll do a couple of interesting cases that I've seen. Sound good?
Sure.
Great. Okay. So basically, I remember this guy. And the funny thing is, it's a small world. I work in Manhattan. I grew up in Bay Ridge, Brooklyn, and I still have dinner out there in Bay Ridge. And this guy actually, he was telling me he was a musician in a restaurant. And, after a couple of visits, we were talking. He's like, I play in Bay Ridge, Brooklyn. And I'm like, I live in Bay Ridge, Brooklyn. Yeah. He's like, oh, I play at Embers. I'm like, I go to Embers all the time. And I don't know, I'd seen this guy play back in my old neighborhood, maybe about 20 miles from the office, but, small world. And I'm glad I was able to take care of him because he wasn't doing well when he walked in. Basically, his story, 57-year-old male, he presented to our clinic with a red eye for 3 days. He was treated by an outside MD, not an ophthalmologist, gentamicin eye drops, and the patient had been using Visine. He had decrease of vision, redness, discomfort with eye movement, especially looking down. And this is kind of a common story you're going to get. Gentamicin, I usually don't use it. It's a harsh drop. And Visine's terrible for the eye. You should never use it. So if anything, he's just compounding the problem. And to break this down, I'm going to kind of translate this to English. His eye is just angry and red. The chemosis is the white part of the eye is just, it's red and bulging out. The cornea is very edematous, very swollen. That's the clear part of the front of the eye. He has a lot of inflammation in the eye, a lot of cells. The eye is scarred down. The pressure is a little bit higher, and we can't see to the back of the eye. This is one of the people that you just walk into the room and you just see right away, and you know something's terribly wrong. So we didn't know what to do. Called in, actually, I was working in the office. It was a busy day, and I called in a couple of my colleagues, and we really, just kind of discussed it. And kind of the big, to think about it, we really were trying to think if it was inflammatory versus infectious. Because again, he's noting discomfort with eye movement and down gaze. So that means that there's something going on behind the eye or around the eye. Because if he's having trouble looking down, there's something more going on there. Now, the problem is infection versus inflammatory. Because infections will have inflammatory components, but at the same time, if you're treating the inflammation, they'll initially get better with an infection perhaps, but then the infection will come roaring back. At the same time, he definitely needed a workup for inflammatory causes, but they're not going to come back in time. And again, that's not really going to guide our treatment immediately. So we really just kind of had to make a decision and run with it and see how he responded. So what we did, we leaned towards the inflammatory part. And again, we didn't even know how to categorize it in terms of inflammatory, because there's different types of, iritis, uveitis, that's inflammation in the eye. There's scleritis, which is inflammation of the white part of the eye. And there's different parts of scleritis, or different versions of scleritis that can actually cause vision loss and be very, very bad. So what we did, we started him on a steroid eye drop every 2 hours. We started him on Valtrex, oral Valtrex. And the reason for that was, again, anything that looks suspicious in the eye that doesn't seem right, can always be herpetic. We see a lot of herpetic disease in the eye. And his pressure was a little bit higher, 24, normal pressure is between 12 and 20. Herpetic disease can cause pressure of the eye to go up. Valtrex has really no systemic side effects. So we always have a very low threshold to start someone on Valtrex, especially if there's anything that doesn't look right or anything like that. And of course, close follow-up. That's a crucial thing. Just have them come back the next day, and that's really important. Comes back the next day. He feels much better. He's happy. He's feeling good. His vision's a little bit better. His pressure's better. His eye looks the same. It's still very inflamed. We do a B scan, and what B scan is an ultrasound of the eye. And what a T sign is, that's looking for a sign of posterior scleritis. Posterior scleritis is a type of inflammation that can cause emergent vision loss that we would need to get him to the hospital for IV treatment. So we didn't have that, so we felt a little bit better. This is also on a Friday, so we're kind of a little bit nervous, going into the weekend with this guy. But what we do now, again, we're trying to just think as well as we can here. And this is where it's really important to just listen to the patient. He looks the same, but he's feeling much better. And he's not worse. Look, visually, he's not worse, and he's feeling much better. So we keep him we don't change anything, because we just think that, just going by what he's saying. And this is where it gets tricky, because I work in different locations and it's a Friday. I'm not in the office until middle of next week. So I put him in with one of my colleagues, my friend's father, who works across the street. And we actually called one of the techs in who's going to be there on Monday. We were like, Danny, look at this guy. Just look at how his eye looks. Tell Arthur exactly how he looks on Monday today. Again, that's very rudimentary, but it was actually really important, because that was going to kind of, our notes can only say so much, and you need that visual, kind of information. Comes back on Monday, same treatment, and we also give him strict instruction. Any vision loss, any changes, ER, just go and get treated. Inflammation's much better. I remember Danny, the tech, came in and he called me and he said that, it looked like a mild allergic conjunctivitis, and I didn't believe him, but I saw him later that week and he actually was much better. So we sent him to his primary care doctor to get a workup for uveitis, because that can be caused by a lot of systemic things. Nothing really came back. So it was a really unusual case in terms of, we didn't get an actual diagnosis in terms of what caused it. But he got much better. His vision came back to normal. He still has some residual scar tissue. Like when his cataract needs to come out, that's going to be a very difficult cataract, because again, for cataract, you got to open up the pupil. And when there's scar tissue, it's not going to open up well. It's not going to dilate well. But he, the eye was able to be, I don't want to say saved. I think that's a little too aggressive to whatever. But he did well. So that was, again, when we talk about gratifying things in the field, this is definitely one of them, that we were able to help this guy. So he would always, when he'd see me at the restaurant, he'd always come over and start talking and be very happy about what we did for him.